So on today's lecture, we are going to be going over intubation and basically advanced airway procedures, and just the beginning of this to get us a good idea of what's going on in class this week. This will be our lab, and we're starting with the basics, and we'll kind of build off of there. So here's where we're starting at, and let's continue on. So I'm sure you've seen 5Ps or 6Ps or 7Ps. But this has to go with a lot in life, but especially with intubation. The good old proper preparation prevents poor performance. There can be extra P's in there with other somewhat explicit wording. But that being said, big thing with intubation in general is trying to prepare yourself for as much as possible. There's crash airway where we still have to try and get certain things prepared, but particularly when we're taking an airway, when we're looking at drug-assisted intubations, things like this, we have a few more minutes. We need to make sure that we are prepared as possible. One other thing that we'll try and do is get you guys checklists out. I'll have them for you guys on Friday, and trying to follow those checklists all the time. It's a pretty important concept to always try and do things as the same as possible. So if there is variances, everything else is the same besides those variances that we cannot control, and we're trying to build like this as a muscle memory, so you're able to still maintain and run a call while you're getting ready to intubate a patient. It's a pretty important thing that we do, because when we screw this up, we can absolutely kill the hell out of our patients, and so we need to make sure that we're going about this the correct way. So failing to prepare is preparing to fail. Another old saying that you've probably heard quite a bit. Airway management is a critical paramedic skill, and it's one that they've always talked about trying to possibly take away from us. They've really gotten away from some of that, and there's a reason behind it. Intubation is a skill within airway management. Airway management as a whole, no matter what, is going to be a huge paramedic skill. Intubation is a skill within that we need to be good at, but it's not necessarily the only skill within airway management. There's a lot that we can do, more advanced and less advanced, that's important with airway management. So paramedics need to be masters at airway management. This is a skill that we need to have and be good. Now, intubation is a little bit different. We are never going to be at that expert level that when we talk about anesthesiologists, CRNAs, but they get thousands of intubations a year. If you're lucky, or if you have a particularly eventful career, you might get 1,000 intubations in your career. Might be some people with more, but in general, particularly since the advent of CPAP and now BiPAP and the pre-hospital environment without vents, that really helped take away a lot of the need to intubate some of our patients, because now we can still provide them with positive pressure ventilation without necessarily intubation. So we're seeing us do this even less and less. That being said, if it's any type of high frequency or low frequency, high risk skill, we need to make sure that we are training up on it as much as possible and to be proficient with it. So starting back in the basics, basic life support and BLS airways, manage our airways correctly with BLS procedures before moving to intubation. Even if we know that we're going to tube this person and we need to prep them, still doing the right things like bagging our patient with a good mask seal is vitally important, and we need to make sure we're doing that correctly. Otherwise, we're going to crash and code our patient when we go to intubate them because they are hypoxic. And so kind of what we're talking about here is using proper basic airway maneuvers, head tilt, chin lift, jaw thrust, BVM, and a good seal and appropriate tidal volumes. Everything that we're doing is very, very important from the BLS skill on up. So as we're preparing our patient, we're looking at trying to get our patient ready as well as get us ready for the procedure, right? Is our location more ideal? Are we just bag valve masking, bagging our patient in the bathroom? Is there enough room to do what we need to do correctly? Sometimes we don't have that option, and we will go over some of this with difficult situations, difficult positioning, things like that we will try and train you to get some experience on. But the biggest thing is to try and make things ideal before trying to intubate our patients. Get that good positioning, get everything that we need correct before we go about this. Maybe we don't even do it in the house. Maybe we get them out to our truck where we have more room, well lit, the family's not there, and we can go there and tube them inside our truck where there's more backup things. We have more oxygen to deal with, our meds there. It's a bit more of a comfort area, right? Or it might just be pulling them out to the living room where we have, or whatever hallway. Instead of doing it right next to the bed, trying to fit into these weird spots, let's try and properly position our patient as much as possible and get our patient ready. Then we start with our pre-oxygenation. We'll talk about high flow nasal cannula, and it's not a special nasal cannula. We're just using our normal nasal cannula as much as we can. And what this does is it provides PEEP, a little bit of PEEP in there, and poor man's PEEP, by just pushing high flow oxygen through tiny tubing. And the other thing it does is during the intubation procedure, we want that O2 flowing the whole time to hopefully provide some passive oxygenation at the same time. While we're getting that high flow nasal cannula going, we'll also have either a non-rebreather if the patient has an intact and adequate respiratory drive, or we're going to be bag valve masking them if respiratory support is needed. And so that's kind of a couple of things that we're going to be looking at trying to do as we're pre-oxygenating our patient. One important concept here is that our patients, that if we can displace and get our PaO2 above that 100, get it up to 200 if we need to. This is one of those times where those free radicals are just fine. We're not too concerned on that because it's a short time period, and what we're trying to do is get as much of that oxygen dissolved into the plasma as possible, so that way during the intubation we have a little bit longer during our intubation procedure before they start desetting. So we're going to be looking at pre-oxygenating our patient, and more importantly, we're going to look at denitrination. Sorry. We're attempting to do this for 3 minutes. The idea behind this is that we're not only just trying to pre-oxygenate our patient, but if we look back to what concentration of air, or what percentage of air in standard room air is oxygen, which is about 21%, and nitrogen, which is about 78%. That nitrogen doesn't do a whole lot, but one of the things that it does do is it takes up a lot of space within our lungs. What we're trying to do in this procedure with this pre-oxygenation or denitrogenation is replace all that nitrogen with 100% oxygen. The idea behind that is that, one, increasing that partial pressure of oxygen, hopefully jumping our PaO2 way up there, 200, maybe 300, as well as when we start the intubation procedure, we're now going to have this patient, the only transfer of gas molecules in the lungs is going to be happening passively on the air that's already there. Hopefully the nasal cannula that we're pushing air through is still helping a little bit of passive oxygenation. But the other thing that we're trying to do is if all that oxygen or all the air in the lung tissue itself in the alveoli is 100% oxygen and not standard room air, it'll give us a longer time before that patient starts to deset, because it'll be just oxygen in there and we're not having to worry about the nitrogen taking up too much of that space. So what it's going to do is increase our intrapulmonary oxygen reserve. So basically all the air that's in our lungs normally, it's going to, instead of having that nitrogen in there, it's going to be oxygen, which will allow us the greatest amount of time to intubate our patient in case we're having some difficulty and without our patient desetting. During apnea, the rate of arterial desaturation depends mainly on the volume of oxygen stored in the lung and on mixed venous oxygen saturation in the presence of an intrapulmonary shunt. So this is kind of what we're trying to best prepare ourselves for the worst case scenario, but as well as making sure our patient is going to be ready for intubation. So while you're pre-oxygenating our patient and denitrogenating our patient, we start getting things out. I always pull out whatever supraglottic I might need. I get a half-size smaller intubation tube, and if I think it's going to be a difficult airway or they're having some type of reactive upper airway thing such as anaphylaxis going on, I might have a half-size smaller and a full-size smaller just on standby. I identify where my cricothyrotomy kit is. I don't need to pull that out, open it, or anything like that. I just go and I make sure everyone in the room is aware and on the same page as I am. Hey, grab the kit, or make sure this is where our kit's at in case anything goes wrong. And it gets everyone on the same page. You pull out your innovation checklist, start going over it, start looking at different things, making sure that you have everything that you need, and it also lets everyone around you know where you're at and what you're thinking. So like here's our supraglottic. This patient looks to be, if it's a eye gel, we're gonna go ahead and have the size 4 on standby or size 5 on standby. You don't have to take it out of the packaging, but have it out there and open. So in case you're unable to get this, you're not panicking and things like that, you just move down the next checklist of failure to intubate. All right, let's see if we can get our supraglottic. Supraglottic work. Yep, cool. We're now good on this as far as our failure to intubate type list. And we'll go over a full list of that as far as it goes as difficult airway and failure to intubate algorithms either today or later. But it's nothing too crazy, but that's kind of what we're looking at. So next thing you need to make sure you have your suction and out and ready. Portable and wall suction have both available. You might need both, and you don't want to be looking for those. Have it turned on and going at this time as well. Don't just have it over there. Yeah, I know where it's at. No, have it out and ready. Have your hard suction ready, as well as have an NG and OG opened and ready to insert as soon as we get the intubation, the tube in place. Next, have our backup airway. Have it out and ready, like I said, whether it's supraglottic, iGel, King, cricothyrotomy, whether it's a needle or surgical, know where it's at. You don't have to necessarily pull it out of there, but make sure you ID that you do have it and you do know where it's at. And then have McGill forceps close by, particularly if that you have any possible obstruction removal or obstruction, foreign body airway obstruction, but you might need it anyways because sometimes there's a big old chunk of food or something else in there that causes them to get to where we need. So as we continue down our list, have our have our BVM with mask ready and have your ETCO2 in place on the bag device. So all you have to do is remove the mask, place it on there, and place the ETCO2 with the BVM directly onto your tube, and you're ready to go. I also have it connected on into my monitor, because that'll help us. And it, especially with the Zols, they take a few breaths for it to go, so you'll have a quicker confirmation when you're ready. And the other thing is, I put the Thomas tube holder or whatever other tube securement device behind the neck and prepared, so when you're ready to secure it, you're not looking around for that. You just clip in and go. Appropriate size for the patient. For most adult males, 7'5" to 8'0". For most females, 6'5" to 7". If it's a little bit taller, and usually we go a little bit more by height, it's less worrying about specific formulas. It's kind of an estimation and kind of what you can get. Remember, the sizes are the width of the tube in millimeters. That's where we get the 6070 numbers from. And so it doesn't necessarily have to do the length, although it does correlate. There is a correlation between the width of them, and the width of an ET tube, and how long the ET tube is. Have your blades out and have just have your whole roll ready to go. Your Mac Miller blade, make that whatever decision you're going with for both DL, and then we should be looking at VL, and I'll get a lot more into VL in a later lesson, but be sure to ready to go with your DL blade as well as your video laryngoscope. Video laryngoscope, if you have the option, should be your go-to. There's times, particularly on codes or other ones, where it's more of kind of getting a skill. It's not a skill. We're still trying to do everything appropriately, but I might want to try with a DL so I can keep that skill up on a real patient. If it's appropriate and it seems like it would be an easier tube, then a DL is absolutely appropriate. If there's any type of difficulty involved, you should be really looking at trying to use VL and using all the techniques that are there. So go there. Talked about our blades last week, but we're going to go over it again. So our Macintosh blade is meant to go into the vallecula. It can be used to directly manipulate the epiglottis as well. And this is your pretty standard for most ER and ER physicians and paramedics. Mac 3 or Mac 4 is typically our go-to for adults. You get some anesthesiologists that get a little bit weird with things, and they can. Because they do it so often, they find whatever is a little bit more custom to them, and everyone will have something that they feel is a little bit better or worse, but here's pretty much what we're working. This tends to be the one that most people go to is our Mac 3 and our Mac 4. Innovation Millers, innovation blades are Millers. These are those Interbright ones. I think I mentioned to a few people that actually have a little bit of a UV light, like a black light, and so it helps glow. It helps the vocal cords actually show up and glow a little bit. Pretty cool devices. Nothing particularly crazy about them otherwise, but they're pretty interesting. I've used them a few times. I like them, but nothing. It's just otherwise. And they have a Mac and Miller. That's just what this happens to be. Straight blade, designed to lift the epiglottis itself. It's not meant to go in the vallecula. Preferred for use in infants up to 2 years of age. It has the best results in that specific. 2 to 4 is where the airway starts changing a bit from our pediatrics, that very infant type airway, to more of an adult looking or small pediatric, younger pediatric airway from like 8. And up to like 8 years old, after that, it's kind of in the middle. And after that, after 8 and up, their airway is very similar to an adult. So those are the kind of, they are the blades that they tend to use. And Miller blades may be considered superior to Macintosh and McCoy blades regarding glottic visualization, ease of intubation in pediatric patients with normal airways. So here's how the different placement looks. I think I kind of showed you guys last week on the mannequin as we are looking at some of these, where the blade goes as far as the Mac right in the vallecula, where we can directly manipulate that and hit that tendon, versus in the versus Miller, which is actually meant to lift the epiglottis up out of the way itself. Video laryngoscopy, when used correctly, provides many advantages over direct. Some video laryngoscopy blades have limitations, especially blades that are hyperangulated only, such as the King Vision. Direct laryngoscopy is more affordable and has fewer complications that can arise from use. We will go over DL versus VL on a bit more later of a date. I did introduce you guys hopefully to most of that topic last week a bit in lab, so we'll continue on. Tube selection, adult male, like I said, 7.5 to 8.5. They're actually going a little bit somewhat smaller, 7.5 to 8.0, or even sometimes not even using AO and just kind of going 7.5 almost. The pediatric age divided by 4 plus 4 equals your uncuffed tube size, and cuffed tube should be a half size smaller from that. Have your 10 cc syringe attached to the tube. There's whole charts on your Brazo as well as everywhere else where they can help give you a better one, but that formula is usually one that you need to be aware of. We look on here, we have the bevel, which is the angle that is sometimes as we're inserting the tube that it'll catch on the cords, and we need to be aware of. Then we have the Murphy's eye, which is that little eye hole right there at the tip. Go down the cuff. On adults, it will fit anywhere from 7 to 10 cc's of air. We're aiming for basically 25 millimeters of mercury of air pressure in there. We'll go over how we can kind of measure that. It's not as important in the immediate pre-hospital, but if you're going to be transporting this patient for a longer amount of time or having elevation changes, making sure to check the amount of pressure that's in there is very important. We have a pilot balloon. If you feel that balloon while the cuff's inflated, it should match basically the amount of pressure that is in the cuff itself. Pilot line, as it goes down and fills up the cuff, and then so the numbers going up are in centimeters, and it's the depth of our tube. And that's basically what that's going to be measuring. And all of the connectors are pretty universal, so they're 15 millimeters. You might notice occasionally that a small pediatric tube might have a slightly smaller, but it's still meant to connect around a standard BVM. It might just go, instead of on the outside of a BVM, on the inside. That might be some other different things that you might see with different BVMs and different tubes. But all of them are still meant to connect to any of the universal ones. So it doesn't matter what tube they're in, it's always going to be that 15 millimeter connector. Introducer device, we have a couple different ones. We have a flexible stylet, standard. It usually is in the tube or is a separate device. Many people will use this one. It's the one that's in the middle there. It can be manipulated to form certain shapes. You have your rigid stylet, your hyperangulated, the one, and I showed many of the group last week. The rigid stylet that I still have around. It's from a glide scope, but there's a couple different ones. Usually they are more device specific because they're meant to match the angle of your hyperangulated blade. And there is certain ones that are designed overall for different areas. So, and then last we have the bougie. Traditionally, it was a rescue device. It was first made as an ET tube exchange device. So what you do is if you're looking to change your tube out, you'd put your bougie in the old tube all the way down till you hit the carina. You would then pull the old tube out and put a new tube over it. However, it has come into vogue. Many places these days use it as the primary go-to, and that is their initial one. They'll use it as kind of an introducer in there to get what they need, and then they'll slide the tube over. We're going to be going over bougie next week, so I'm not going to spend too much time. If we get a little time in class during lab, I might show you guys begin some of that so we're more familiar for the next week. But in general, it's now pretty standard to use. It used to be more of a rescue here. Everything else is going wrong. Let's go ahead and get use out of it, or use this instead. Being said, it's a pretty useful device. I like using it now. If I'm not using a rigid, I'll usually use a bougie, and sometimes it just depends on the patient. So we'll go over bougie use a little bit more next week. So here's a flexible stylet. Sometimes you'll see some people just want to keep it straight. Some people add a little bit of a bend in there. Some people add a crazy bend in there. I prefer to use relatively straight, maybe a little bit of a uptick at the end. But even that one is we see on the left, the A example is it's a pretty steep bend that I don't necessarily use. I can and will for certain patients, but it's not my standard go-to. Rigid stylet, here's some different examples of that, CMAC versus all these different ones. And when I go over video, I'll show you guys some of the specifics on that, on these in particular, and especially right before you go to OR and do some other ones, make sure you guys are familiar. We'll do a review of video because sometimes they will allow you guys to do video laryngoscopy. And particularly if they'll ask if you're comfortable with it, and if you are, absolutely go ahead and use that. It's great. Continue on. Bougie. So this is kind of how I end up holding it. A couple different ways to look at this. So typically, standard bougie is a two-person procedure where the first person you get the bougie in where it needs to go, and by using the kind of that hang loose signal, you get some fine control. And I'll show you guys with your pinky where you can kind of pop up that end. When we over here on the right, we see I will show you guys how to do this so you can one person it. This is actually a relatively one of my medics I was training in at Guardian Air on difficult airway. He's like, oh, I wanted to kind of loop it like this, and I guess I'll show you a pretty useful way and how you can make this work pretty effectively. One hand pop it through and go through. If you guys notice a little angled tip over here as it goes up at the end, that is called a coude tip, and it's kind of able to help you to make sure it's going interiorly and in the correct spot. So there are multiple ways to prepare your equipment. Always try to do as similarly as you can every time, and that will help you make sure you don't miss things. So set it up consistently and try and do it the same way every time. In EMS, we end up seeing a number of locations, so it's not always we can't set it up exactly the same, but if you try and set up as many things as the same as possible, when you do have any of those new changes or alterations, it allows you to keep everything else as the same, as similar as you possible, so then it allows you to be more fluid and able to adjust to some of the other intricacy or the other changes that you might be dealing with. Basically what we're talking about. So push dose pressors. We're going to get quite a bit more into this here in a few weeks when we get into medications, DAI, so drug assisted intubation, and RSI, rapid sequence intubation. But in general, when we go to intubate, many times we cause the patient begins to decompensate, and we need to be able to deal with them decompensating quickly. And so having that push dose pressure already drawn up and ready goes a very long way to making sure things are prepped and ready to go. So this is one that I recommend having it drawn up, ready, labeled, epi 1 in 10, 1 in 100,000. And we'll show you guys all this coming up, but you just have it there. You don't necessarily need to connect it, but if they do and they have semi-soft pressures, even not necessarily below 90 yet, go ahead and hit them with a little push dose pressure, because as soon as we give them induction medications and start manipulating that airway, there's a decent chance we're going to cause them that blood pressure to drop, and if it's already borderline, it's going to cause them to possibly code or get very close to that. So relatively important concept as we go through that. Induction agents, we're going to get a bit more into this on DAI and RSI day, but choose the medications most right for the patient, whether it's ketamine, etomidate, or Versed. Versed tends to be the least preferred most of the time, just due to patient its effect on patient hemodynamics. It's not every time, but many times. So we'll talk about that a little bit more, and which paralytic rock or sucks, and rock sucks. We get a lot more into this later. There's a time and place for sucks, but not very many. Checklist, we will give you guys a checklist. I made them wallet size so you can throw it in the back of your ID card or in your wallet. I recommend using these. I use them to this day. I find them extremely helpful and useful. Highly recommend to go ahead and use those. It makes life nice for me. I like them, but that's me. So the thing we'll look at trying to do is, since you have a checklist, we need to be using it. I will go over the reasoning behind this, but in reality, it's a pretty important idea to try and use these as much as possible. It reduces cognitive load by a ton. There's been quite a few calls where when I didn't use my checklist, all of a sudden I was missing things. The idea behind this isn't, we want you to remember all the things, of course, but pilots, many doctors use these. Pilots use them all the time in these high stress situations. We're looking at cognitive offloading. We want to be paying attention to the situation itself and not worried about the equipment that we have available to us. That's kind of the reasoning behind these and why we want to make sure to use them. There's a ton of studies that show basically during high stress situations, in general, we're only able to remember 5 to 7 things, and when we get into higher stress situations, we're basically only able to remember like 3 to 5. And we want those things to be thinking about, did I bring the checklist? Okay, I'm going to go over that, and you're going to be surprised at some time of how much it actually helps when you're trying to and stress relief. You're like, cool, I know I got all my stuff. I'm going to the checklist. I have it, and it just relieves a bunch of the stress that normally is associated with some of these calls, particularly like high stress calls. Hopefully at one point intubating a patient's not going to be that stressful of a thing for you, but particularly early in your career, it definitely is. So don't let your ego get in the way of providing the best care to the patient. So here's kind of what I was talking about. In the work of psychology of memory found that we can retrieve 7 plus or minus 2 pieces of information from our memory with relative accuracy. When complex procedures, stress, or fatigue are introduced, our memory becomes increasingly unreliable. As the number of task problems we simultaneously manage exceeds 3, we show a significant decline in the accuracy and speed of handling these tasks and problems. This is why the idea behind checklists and cognitive offloading is so important, because you now have particularly if you start building this up almost as a muscle memory skill, then you're not concentrating on the skill as much. If you reduce some of that cognitive stress of the situation, it basically allows you to really focus on your overall patient care and a lot less on wondering if you have all the equipment, if you're doing things correctly. That's kind of the big reasoning behind why using cognitive offloading, using some of these checklists, using other things, when you have a pediatric patient, using apps, things like that are pretty important to try and still provide the best care for our patient, not just can you hurry up and memorize everything that you see on this. And big proponent of it. Most flight organizations that I've worked for have used a checklist in one form or fashion, and that's basically where I developed the one that we have here. I tried to get rid of some of the RSI are in the heavy CCT side of things to make it practical and just a sense for us here at PIME. Here is an example of the checklist. It might be slightly modified when we look at it compared to the one you might get, because I might have made a couple changes. I've made a couple slight small alterations. Some of it's just formatting and things that we need to be aware of. So we stop and prepare. So you pull it out, you go with it. One flight organization made it. They actually made us like say it all back and forth with one another, and it didn't seem as practical to me to quite do that. But at least start going through this list and verbally kind of go over it. Assign roles, such as innovator. Hey, you're going to help me this. You're going to be on medications. You're going to be on monitor. Things like that. Make sure our location that we're doing the procedure is optimal. And then recognize our backup plan and what we need. And then we're going to start. We're going to pre-oxygenate our patient. Make sure our head of bed is elevated. High flow nasal, if we can. High flow nasal cannula, and then NRB or BVM. Equipment, make sure we have our tube, our introducer, our blades, our suction, and ETCO2 connected to our BVM. Then we're going to start prepping, make sure our patient's positioning, whether we need to ramp, pad shoulders, a number of different things that we'll look at for difficult airways and similar. And then we will make sure that our patient is resuscitated before we decide to intubate. This is a huge thing that many of us in pre-hospital forget, and it's a very important concept to try and make sure that we do correctly. By resuscitating before we intubate, we're now not causing our patient to code, and we don't want the airway procedure to cause the code. Occasionally it happens, and you go, if I don't get this airway, they're going to die anyways, and so we're going to try and do this. But resuscitation before intubation is a huge, important concept we need to make sure that we're trying to do. Our pre-medications, make sure we have our push-dose pressor out, our paralytic out, and our induction agent. This is not necessarily the order that we put this in. This is there. I think that was one of the changes that might be different on one of your on the new ones, or it might still be the same, but no, when I get into RSIDS, I will talk about the order to push medications, and it's always induction agent first. Push dose pressor might be first, and then induction agent, and then paralytic last. We don't want to paralyze a patient while they are still conscious and able to think and remember things. Next, and we're just getting all those medications out and getting them ready to go. We should probably, and we're going to be assessing for our difficult airway things using Patty in our 3-3-2 rule. And then we're looking for dirty airway or obstructions, have our suction and our McGill's on standby and ready to go. If we're using video, we're going to be leading with suction every time we use video. That should not ever be an option. It should just be the way to do it, so you can prevent getting your airway all messed up and our airway, but our video laryngoscope video all fogged up and unusable. That's the reasoning behind it, because most people who complain about video always say, oh, I got the camera obstructed and I wasn't able to use it well. So we'll go over the salad technique and all that in the future. Then post-intubation, we're confirming lung sounds and ETCO2. We're securing the device and we are checking vitals. Immediately check, and then NGOG and post-intubation sedation and analgesia. We're going to go over all this a bit at some of the specific stuff that I had mentioned, medications, things like that, at a later lesson. Today is going to be just the procedure itself. So go in there. So time to start. Patient should be pre-oxygenated and denitrogenated. Equipment set up and ready to go. We have our backups in place. We know where everything's at. We're ready. We have our suction. We have our tube securement device behind the neck ready to be secured. Suction is on and ready. OG is ready to insert. ETCO2 connected to a BVM is ready with mask if we're not already bag valve masking our patients. All right, starting our patient prep. Our head is on a bed in a neutral, if that's in a neutral position. We're going to start hyperangulating, or we're going to be angulating our patient as much as we can. And if we're unable to, due to anatomical issues such as kyphosis or pathological issues such as them already being or them having a possible C-spine fracture, anything like that, where we're unable to move the neck around, and we're going to be using our DL hyperangulated blade, our VL hyperangulated blade especially. Also, what we're going to be looking at doing is trying to get just that angle. We're trying to line up that oral axis with the pharyngeal and laryngeal axes to give us the best view that we can. Talked about this a bit, but we're going to go again. We really need to make sure that if by lining everything up, it's going to allow that tube to both you identify the location where it needs to go, and we identify that glottic opening, as well as advancing the tube past it. If you have too steep of an angle, many times it makes advancing the tube very difficult. On the right is what we call ramping the patient, particularly with bigger, heavier patients. It allows them to still kind of breathe a little bit, but also angling it right. And this can be very useful, particularly on those very large patients. Medication, once again, we're going to go over medication a little bit later. However, resuscitate before we intubate. If the patient's hypertensive or even borderline, we're going to go ahead and use those push dose pressors. We're also going to make sure we had fluid going prior if we needed to. With that being said, have the push dose pressor ready to go. So we'll talk a little bit quick introduction to these medications, but like I said, once again, the DAI RSI lecture will be in the future. But some quick things just to get an idea of what we're talking about. Etomidate is short-acting, has hypnotic effects that act on the GABA receptors. It lasts about 5 to 7 minutes. Multiple doses can cause adrenal suppression. So when we talk about some of the reasons that we might choose one or the other, those are a couple of the big ones right there. Can cause a short period of apnea, but overall it is hemodynamically stable, and it's one of the reasons that it's a very common drug that we use. Next, ketamine, longer lasting dissociative medication that affects NMDA receptors. This is an important kind of concept in the sense that we need to make sure that we are using the right medications for the right person and condition. So we talk about this. It's a very useful medication. It also has some other interesting effects. It acts on opiate receptors with analgesic properties, so it affects pain, which is a very important type concept when it comes to intubation. Next, its onset was roughly 30 seconds VIV, 3 to 4 minutes IM, and it lasts 10 to 25 minutes, sometimes up to 45. Has analgesic properties. If the body is catecholamic depleted and having been in a shock state, it can cause some hypotension. Normally, it doesn't affect the respiratory drive. So in general, it is a very useful drug to use because it doesn't affect hemodynamic properties. Neither is etomidate. They're both. It's one of the reasons that they're used many times is because they don't affect the hemodynamics very much. They can, but not as much. Benzodiazepine, Versed, which is a benzo, and you'll see some other ones sometimes use Ativan and or Valium, but typically Versed, especially in the RSI one, is a little bit more. It's a little bit faster acting than the other two. 15 to 25 minute duration of action. IV, IM, or IO does cause hypotension. It absolutely does. And so we have to be quicker on the push dose pressors, things like that. Our two paralytics, we have succinylcholine. It's a short-acting depolarizing paralytic. Onset's about a minute, and it lasts about it causes fasciculations, it causes the whole body to kind of convulse. So what it does is it causes all the muscles to basically activate, and then it keeps them activated. Has many contraindications, including burn, crush injuries, hyperkalemia. So it has a ton of things that we need to be aware of, but it doesn't. And so when we look at that compared to rocuronium doesn't have nearly as many, and it's why many times rocuronium is preferred medication in RSI. Rocuronium is a non-depolarizing paralytic, so it doesn't cause all those fasciculations in the muscles to just spasm out. Onset's 1 to 3 minutes faster if more is used. It lasts 30 minutes longer with higher dosages. It's non-depolarizing, has few side effects, however, can cause mild hypotension. So it's go time. We're going to go ahead and do the intubation procedure, and I will walk you through this on Friday, and we're going to go through it all. And upon confirmation of sedation and paralyzation, we go ahead. We use a 2-finger scissor technique. You might not like this technique as much. However, when you're in the OR, it is used all the time. And the anesthesiologist and CRNAs will expect you to use this procedure. So know it's a scissoring technique. You're going to go ahead and open it. We tend to get out of that habit in the classroom because the mannequins don't typically have, or their mouths are kind of already open, and so we don't necessarily need to use this, but on a real live patient, you are going to need to use it somewhat. All right, so you're going to advance the blade slowly. You're going to be identifying landmarks as you go down. This is an important concept because we want to make sure that we are going to the right spot, and the only way we can confirm that is by the landmarks that we're finding. So it's a pretty important idea to move down slowly and not just shove the blade deep as you can, and to be ready and to just kind of go down, identifying as you go. Identifying places that you might need to use suction, things like that, and just kind of keep going down. We put it basically on our right side. Well, it'll be the patient's right side too, because we are looking down their mouth hole. And you're going to sweep the tongue to the left as you advance the blade towards the vallecula and / epiglottis. As we do this, we're going to, once we're kind of in place, this is finite movements of the hand, we're slowly getting there. And once we're into the vallecula, at that point, we're going to lift up and away towards the top corner of the opposite side of the room. You're moving at a 45-degree angle. The idea here is once the blade is in the vallecula, you are lifting up and you're moving the mandible and the tongue all out of the way. And so we're lifting up and away, and we don't rotate back towards us. Stooping, try not to stoop, stand back, and you're going to have a much better view. Now, there's times where you kind of have to. But twofold: one, you're going to have a worse view, but also the further back you are, you make some slight adjustments. You're not going to lose the chords. When you're real close as well, another thing, it doesn't take much, but if all of a sudden the patient vomits or coughs up things, it's going to get right in your face. It's a number of reasons why we want to have a little bit further back view. As I don't have as good of able to angle and be able to lift as well. So there's a number of reasons why you want to make sure you have that, you're a little bit further back. So proper place that Macintosh right into the vallecula. And then you can see as we lift up that entire area towards the top third, it'll open up the airway and make it it'll allow you to get a much better visualization. And we can directly manipulate the epiglottis too. Here's kind of the same, the angles that we're looking. You don't get as good of a lift typically with the Miller, but you can. And identifying that, so we're sweeping up over to the left. You may need, depending on the patient's anatomy, to have your partner over there assisting with moving part of the body parts out of the way. It's why having a other medic there, or even a partner that you trust and kind of know what you do, is useful. Typically in the vallecula, and then once we identify, we start advancing our either introducer device, or such as the bougie, or our tube. So we start advancing one or the other, whatever we have there available, and what that we've chosen. Sometimes it's chosen for us, particularly in the OR. They let you know what you're going to use. Make sure the end of the stylet is not past the tube. It's right there in the bend. Pre-shape if needed. And multiple shapes have been recognized as useful. So if you find one that really works for you, go with it. Your partner might have one. You and your partner might have different ones. Well, sometimes it has to do with anatomy and how you go about it. Bougie, it's traditionally a 2-person, can be used as one. If it's preloaded, I recommend using the shortened version, and what you do is you put it right through the eyelet. And if you have a little bit out, I'll show you guys a slightly different modified way of this that I really like, because it allows you to push that through real quick and makes it easy. 2-person bougie, the person who's tubing puts it through, then has their partner line up put the tube on the end of the bougie, places it through, and then once the intubator has it in the correct position, they're going to go ahead and say, all right, tube's good, go ahead and pull the bougie, and they're making sure you're doing everything nice and slow because we don't want to accidentally pull the tube. So after that, remove the introducer, fill up this, leave the blade in place. I leave the blade in place the entire time in case I need to confirm things or whatever else. And then I remove the stylet or bougie. You fill up the cuff and just try not to overfill. Confirm. Negative epigastric sounds first, then positive bilateral lung sounds. ETC O2 waveform preferred, numeric sufficient, gold standard. Color metric still used in some places. Clearing hospitals less than ideal and hard to prove. Hit print and snapshot right away to record your positive ETCO2 findings. For you guys at the private ambulances, if you don't do this, particularly the AMR Medic West ones, you will be put on your last and final. This is a huge, important concept. And it's not them being spiteful or anything like that. It's an important idea that we make sure we have correct placement and we don't have it in the gut. A gut tube is never okay. If you do notice that it's in the gut, just pull it immediately. That's the biggest thing with that. Just pull your tube immediately. Or if you can't confirm it's in the lungs, we have to assume it's in the guts. The esophageal tube is never okay. Secure, never let go of a unsecured airway. And some people will never let go of that tube until they hand it over to a doc or ER. But commercial devices are fantastic. Here's Thomas tube holder. There's a couple versions of that same tube holder. Nice thing about the one on the left is that it has a little push button lock unlock thing, so you can actually throw an eye gel in there and you can just slide it out and then screw in the proper tightness. But normal one works just fine. Use both. Like both, they work. It's great. NG, OG, place as soon as possible, particularly, especially more important in patients that we've been bagging for a while. By the BBM procedure in and of itself causes gastric filling. We're pushing air, positive pressure air into the stomach. Once it starts getting big, it's going to have that increased chance of vomiting. Aspiration is a huge issue. We need to make sure that we need to decompress the stomach full of air, and then also we can pull some of that stomach contents out so we reduce the risk of aspiration. There's a hole in the Thomas tube holder for an oral gastric, bag valve mask causing all this. And low pressure suction after placement doesn't need to be constantly going intermittently or when you need it to. Make sure the tube's lubed as you advance it, and you just advance it on down and get practice doing this as well. All right, guys, if you have any questions, go ahead and let me know. This has been our innovation presentation, and we will be tubing on Friday. So let's get going. Thanks, guys. Have a great day.